Hello everyone, my name is Ana Oaknin. I'm medical oncology by training and I'm heading gynecological cancer program at Vall d'Hebron Institute of Oncology in Barcelona, Spain. It's my great pleasure to summarize our phase 3 study BEATcc, a randomized phase 3 trial, first-line atezolizumab combined with bevacizumab and a platinum doublet for metastatic, persistent, or recurrent cervical cancer. The biology or the rationale for our study was to understand whether adding anti-PD-L1 agent to anti-VEGF therapy will be able to improve the outcome for our patient with metastatic recurrent cervical cancer. With this idea in mind, we decided to launch the BEATcc study. The BEATcc study is an open-label, multi-center, randomized phase 3 trial. In all comer population, we enroll patients with metastatic, persistent, or recurrent cervical cancer. Patients must have not received prior systemic anti-cancer therapy for recurrent metastatic disease, and then we exclude those patients with a high risk to develop bevacizumab toxicity, mainly, to reduce the risk of fistula. So those patients who had pelvic disease, with bladder or rectal mucosal involvement, were not included in this trial. In addition, I would like to stress that we enroll an all-comer population. It means that we enroll all patients without the knowledge of PD-L1 status. Then we randomize the patient in a one-to-one fashion to receive the standard of care established by GOG 240. It means bevacizumab plus paclitaxel plus platinum every 3 weeks, and then those patients to the experimental arm, and then we add atezolizumab to the standard arm. All patients continue the therapy until disease progression or unacceptable toxicity. However, those patients who had achieved a complete response after 6 cycles of therapy, they could stop chemotherapy and continue on biological therapy. I would like to remark that the trial has 3 stratification factors: prior concurrent chemoradiation, histology, squamous versus adenocarcinoma, and chemotherapy backbone, either cisplatin versus carboplatin. The dual primary endpoint for the study was investigator-assessed PFS and overall survival. The main characteristic for the patient were well balanced between the both arms. I would like to point out that approximately 22% of the patients had metastatic disease at screening. Approximately 50% of the patients had pelvic and distal disease at the time of study entry, and 60% of the patients had received previous chemoradiation with or without surgery. And then the primary endpoint, the dual primary endpoint. Firstly, PFS. The study met its primary endpoint, combining atezolizumab with bevacizumab and chemotherapy reduced the risk of progression or death by 38%, with a hazard ratio 0.62. The median PFS was 13.7 months in the experimental arm, atezo plus best plus chemotherapy, compared with 10.4 months in the standard arm. And in addition, a very important, the other primary endpoint, the overall survival, was also positive, with a hazard ratio 0.68. Adding atezolizumab to bevacizumab plus chemotherapy reduced in 32% the risk of death. The median overall survival was 22.8 months in the standard arm, increasing to 32.1 months in the experimental arm, more than 2.5 year median overall survival. In addition, I would like to stress that 49% of the patients in the standard arm were alive at 2 years. However, this figure was 61% in the experimental arm. I would like to repeat, this is a benchmark. 61% of the patients were alive in the experimental arms at 2 years. When we look at the analysis of subgroup, all patients, included in this analysis get a consistent benefit. In terms of secondary endpoint, I would like to remark that the overall response rate and duration of response was significantly increased with the addition of atezolizumab. Indeed, the complete response were 32% in the atezolizumab arm compared with 20% in the standard arm. Turning to safety, the addition of atezolizumab didn't increase in a significant manner the adverse events, as remarked by the fact that the grade 3 or greater adverse events were very similar in the experimental arm, standard arm. In addition, the adverse event of special interest for bevacizumab had exactly the same incidence in both arms, and the adverse event leading to any treatment discontinuation was equal 50% in the experimental arm compared with 60% in a standard arm. In summary, we can say that the BEATcc trial confirms the clinical benefit of combining immunosuppression inhibition with angiogenesis inhibition in recurrent metastatic cervical cancer. Adding atezolizumab to bevacizumab plus chemotherapy provide a statistical and significant and clinically meaningful improvement in PFS and overall survival in patients with recurrent metastatic cervical cancer. There's also meaningful improvement in all key secondary endpoints. So in light of all this outcome, we can state that atezolizumab in combination with bevacizumab added to platinum-based chemotherapy should be considered a new first-line therapy option for patients with metastatic, persistent, or recurrent cervical cancer. I think the BEATcc trial, the combination of atezolizumab plus bevacizumab plus chemotherapy, is a great option for those patients with metastatic recurrent cervical cancer that we consider suitable for bevacizumab. As you know very well, our standard of care was based in bevacizumab plus chemotherapy according to the GOG 240, but with this trial, the 2-year overall survival was less than 40%. I think that with the incorporation of atezolizumab, we have been able to raise the bar in overall survival, and now 61 of the patients are still alive after 2 years. So I think, the BEATcc trial opens a new therapy option for our patients with metastatic cervical cancer, significantly increasing the long-term outcome for these patients.